welcome to Simcast, a podcast brought to you by the Society for Imaging, Informatics, and Medicine. Greetings, Simcasters. Back in 2019, some of you may remember when our Simcast team had the pleasure of interviewing Ben from Korle-Bu Hospital in Accra, Ghana, as well as our very own Jason Nagels, talking about their experiences working in conjunction with Rad 8 International, IBM Watson Health, and of course SIM, to establish a RIS-PACS implementation at the Korle-Bu Teaching Hospital. Fast forwarding nearly 3 years, the team reconvenes to talk about challenges faced since, exciting innovations and integrations with nationalizing identification and public health initiatives, as well as reminiscing about some of the interesting challenges that the team faced, as well as the innovative approaches that resource constraints fostered. It's always heartening to see when technology transfer projects lead to long-term sustainable improvements in both access and quality of healthcare. We hope you enjoyed this episode.
Well, thanks for joining Simcast. And with us today, we have Ben, who joined us way back on Simcast in 2019. Ben is at the Korle-Bu Teaching Hospital in Accra, Ghana. And back then, we chatted about the implementation of a new RIS that was going in at Korle-Bu, or KBTH. And this was part of a Rad 8 program. So I guess, Ben, maybe you could explain for our listeners a bit about Korle-Bu Teaching Hospital and how you were introduced to SIM.
All right. Thank you so much, Jason. I'm very delighted to be part of Simcast this year. Yes, as you rightly said, I've been in Korle-Bu since 2015 as the IT PACS manager. And Korle-Bu Teaching Hospital apparently is the first teaching hospital in Ghana and the third largest teaching hospital in Africa. And how I was introduced to SIM, I think in 2018, 2019, Jason Nagels was sent as a volunteer with the Rad 8 SIM program to Ghana, KBTH to be specific, to help with the implementation of the RIS. And so after the RIS was implemented and it was led by Jason, played an integral role in helping the radiology department to roll on to the radiology information system by IBM Watson Health. That's a merged RIS. And so from there, Jason introduced me to SIM. And that's how come I took part in Simcast 2019. And once again, I'm excited to be part of this year's edition. Yes, thank you.
So, Ben, I understand there's a recent project to replace the existing RIS, which you said, I believe, was IBM Watson. Can you provide a little bit of background into why the new transition, how you went about choosing the new RIS, and what are your expectations of this new solution?
So the objective was not to replace RIS. That wasn't the objective, but there has been a government initiative, that's the government of Ghana, e-project. Okay, so when you talk of e-project, we are looking at digitizing all our major infrastructure, health, education, agriculture, governance, everything. And so as part of the e-health program rolled out by the government of Ghana, there was this EMR that is being rolled out from the teaching hospitals to regional hospitals to district hospitals. And so it was just about the time when we started using RIS that the implementation of the EMR, actually an EMR that was introduced to the hospital. And so most of the roles the RIS will play, the EMR was playing that role as well. And so we couldn't have used systems, okay, in terms of patient registration, scheduling, order scheduling, and then pushing others to the modalities. And so that's how come we had to put the RIS on hold and then get along with the new EMR. That is the Light Wave Health Information System, LIMS. That's what happened. But the objective wasn't to replace RIS. It was just along the way, once the EMR came into effect, we had to hold on with one, that is the merge risk.
Wow, Ben, that sounds like a very large and promising government initiative.
Yes, exactly.
I'm curious, Ben. One of the things you mentioned was patient registration. And I recall when we were together back in 2018, patient registration was a big challenge. Many patients, they share the same name. Sometimes birth dates are not known. Has there been a more, I guess, holistic attack at a governance level? Is the country of Ghana looking at improving patient registration with process, or how is that being undertaken, or is that still a current challenge today?
All right. So if I understand you clearly, you are talking about reducing or controlling duplicates and then redundant data. All right. So as part of the Ghana Digital Initiative, this ID project that is being rolled out, that's the National Identification Card, what we call the Ghana card. So we have a number of cards that uniquely identifies you as a Ghanaian. We have the National Health Insurance Card, we have the driver's license, we have the voter's card, and we have the passport, we have the birth cert. And so all these repository of database, or let's say identification cards, are being synchronized into one. And so currently, when you come for patient registration, your identification number will have to be taken, either your voter's ID, your national ID, but largely the national health insurance card is what is requested. And so all other cards are being synchronized into one big database. By so doing, it reduces or controls duplicate and then redundant data. Yes, that's what is being done. As we speak now, the Ghana card is in full force. The government of Ghana is pushing that agenda that there's going to come a time now we are synchronizing, verifying our SIM cards with our national ID. And so there is this generic card, or should I say a standard card, the Ghana card that every Ghanaian has to verify with his SIM card, that is his calling card, your mobile vendor. You have to go to your mobile vendor to be able to synchronize your SIM card with your Ghana card. And by so doing, if you come to the hospital and you are registered as a patient, once your ID is queried from a database, there is going to be only one entity. That is, if you are the bearer of the ID number, you are the only person whose name will pop up. And even if there are duplicates, the centralization of the database is going to improve to reduce the duplicates and the redundant. I wouldn't say we are there 100%, but I think that the steps taken by the government of Ghana in a long way is going to streamline data. Yes.
Ben, I'd like to ask a follow-up if you don't mind. One thing you mentioned was that this is a government initiative. The government is trying to digitize Ghana as much as possible. And that sounds very interesting and very ambitious initiative, generally speaking. I'm curious, within the healthcare realm, as far as your hospital is concerned, what was that process like? So things, for example, like were you consulted as far as what vendor they selected? You mentioned IBM Watson. Was the process lengthy? We usually joke about governments and a lot of back and forth and paperwork. Did you feel like this was a lean initiative? Please tell us.
The IBM Watson Health was through Radiate International, a non-profit organization in the US, who came to do feasibility studies as part of their feasibility studies in developing countries. Ghana was selected, and then Kolebu Teaching Hospital was also selected for the assessment. So after the assessment, that Merge Packs was recommended as a free bono solution for our imaging. And so we have used packs from 2016 up to 2019, where it was necessary to procure the risk as well. And so it wasn't like from the beginning, Kolebu had to engage IBM Watson to procure or patronize their product or solution. It was through a non-profit organization that donated it to us. And so we started using it. I'm not sure if I've answered your question rightly.
Yeah, you did. That was great. The only other thing I'm not sure if you addressed is I'm curious, like, did you feel like the process was taking too long? Again, governments are typically known for moving slow. Did you feel like it was a lot of back and forth, or did you feel like it was nice and quick?
Are you talking about the merge race or the EMR? Was it a merge race or EMR?
Either one.
Merge race, as I said, we're already using the merge packs. That later we got to know Merge Healthcare has sold it, or IBM Watson Health now owns Merge Healthcare. And so with that one, I believe Radi International already has an agreement with IBM Watson Health, and then we are the beneficiaries. I'm not sure who were involved in terms of cost-wise or negotiations. We were not in the picture. All I know is Kolebu benefited from Rad 8's negotiations with IBM Watson Health. And then with the EMR, that's the Lightwave Health Information System. Once again, the Government of Ghana initiative, and I believe all the bureaucracies and the politics played out up there, that is with the ministry. And so myself, we at Kolebu Teaching Hospital, I can speak little of how, if I can put it this way, how the contract was awarded. Yes. All we know is Government of Ghana has accepted this agreement or has gone into agreement with Lightwave to procure or deploy this EMR in all our hospitals. Yes.
So, Ben, with the RIS implementation, there was slow adoption. How has the adoption been with the new EMR? And were there any different or particular training methods you used during this implementation to help get people up to speed with the new EMR?
All right. So I'll say that Jason was right to include me on the Simcast. Coincidentally or fortunately, I'm the lead from the KBTH software team with respect to ensuring that the software is deployed smoothly in the hospital. And so I pretty much have been involved from user requirements through joint application development to user acceptance tests to training and then deployment. So that has been the project flow. The project starts with gathering user requirements, and then they come back to do joint application development. And then as we engage the various stakeholders, we plan on training. I think it will be important to mention that in 2014, I actually mentioned I've been working with Kolebu 2015. Yes, that is on Kolebu's payroll, but I did my national service in 2013. And so there was a similar Government of Ghana initiative, e-health project, that was rolled out in 2014. And I was pushed to become a trainer or e-health officer for that vendor. And so I was training for that vendor. And that was an Indian company, Indian software. And there were little issues with the software. And so when the first e-health project didn't succeed, this new EMR that came, it's also an Indian software. The first one wasn't web-based. The first e-health project that was deployed in 2014 is a .NET application. And so you need to install server, client application, back and forth, updating .NET, patches here and there. And so this new e-health project learned the mistakes of the first one. And so users or everyone we expect to use the system, we're checking through thorough training. So training sessions were designed. So we have the OPD, those are the patient registration, and then billing. We have the accounts also coming on separate days for training. And even before the major training, we have what we call the champion users. So for every level in the workflow, for example, you come to radiology, before we meet all technologists to train, we select about 2 or 3 heads or leads from the technology to go through the system. So that's joint application develop JAD sessions, then UAT sessions. So it's from the JAD and UAT sessions that system becomes close to perfect to meet users' expectation. And so when training is called, already the champion users or the leaders of the various units have fair idea of what the software is about. And so they help in training. And then as the software is deployed and users use it in their various workplaces, the vendor provided reps, so to speak, officers. So we had lightweight officers. I mean, they were Ghanaians. They employed or recruited Ghanaians to help with the project. And so for every department that went live with this new EMR, there were sufficient e-health officers manning the various workflow points so as to encourage and support the users with the software. And when they encounter challenges, they report directly to the e-health officers, and then they liaise with the IT managers for the respective departments. And then issues are carried on to developers to make changes. And then that's how the software was deployed and training and then using the system. Yes.
Thanks, Ben. Yeah, it's a lot of work, training and getting people up to speed and then making sure they're actually using the system. I want to ask a question, just taking a bit of just one little step back. Again, but I remember the patient registration being a big challenge. When we were putting in that risk, one of the goals were to be able to create a longitudinal record of that patient's history. And that's challenging when you're not consistently assigning the same MRN to that patient over and over again because of poor registration practices or whatever. So I'm curious now that the EMR is in place and you have this national identifying card that is associated to their mobile device and is going to be with them at all times. So I'm curious, were there measurable benefits that you saw from this? Are the radiologists now seeing a more complete picture of the patient's history as a result of these improved registration practices?
All right. So I believe you are asking about, yes, tracking patient history. Currently, the EMR assigned ID, that is the patient ID, has become the MRN that goes through the PAC system. And then that's how the radiologists identify the patient. During integration, go to a time where we had to integrate the EMR with our PAC system. And so there was a question whether to merge the old set of data with the new assigned IDs from the new EMR. It was a little bit tricky, but what we concluded on was not to merge. Okay, so we had old sets of data that was populated by the race, and it had its own set of series of ID assigned. And so the new EMR also has its own set of IDs assigned to patients. Though they seem disparate, want of better word, are able to track past data of particular patient. Yes, I believe if we had merged the old set of data from the regenerated MRNs with the current EMR that has been deployed, it will be much easier, seamless to just query patients' prior images. But the decision was not to merge. We wanted to have a disparate set of data points so that when you are querying a particular data set, you'll know exactly what ID structure to use, whether you are using the regenerated IDs, MRS, or you're using the EMR set of MRN. So that's what happened. Currently, that's how radiologists and all other clinicians are able to track patient data with the study dates, and then with other demographics of the patient, they're able to narrow down to identify a particular patient with the attribute.
So, Ben, we're talking a bit about the registration and the patient ID and whatnot, and using demographics. At least here in this country, gender is becoming more fluid and not as assigned as biological sex. So I was curious, in how are you guys facing the challenge of gender versus biological sex with this new EMR? Is it designed for it, or do you have to have workarounds so that we can provide appropriate patient care?
Well, I don't think it's much of a challenge. What the EMR provides is male, female, other, and then that's it. Because we receive foreign patients too, so there's not much of a problem. Yeah.
So would love to hear more about some of the other systems that you've recently set up at the hospital. And we're also curious, what's the ratio of open source versus commercial software?
Yeah, so open source, yes, in general, I can say we do 70-30, 70 open source and then maybe 30% commercial. That I can speak to, yeah.
So do you use anything that is open source in medical imaging, or is it all commercial?
With medical imaging, it's not open source, though it's commercial. We did not buy it. It's mostly donated, gifted to the hospital. So for medical softwares, they are not open source.
Understand.
Though commercial, Kolebu doesn't pay for, yes, it's usually gifted. Except for this EMR that I'm sure maybe MOH, Government of Ghana, paid for.
I recall, Ben, when we were there, you were explaining, I think, the history of the packs at KBTH, and there was the merge packs. But before that, did you have an open source solution that you were using back then, before the commercial product was provided by RadAid?
Before 2016, we're using a clear canvas, also donated by RadAid. So I'm sure RadAid has some agreement with the clear canvas team to be able to procure the clear canvas for Kolebu. And so, though it's commercial, Kolebu did not pay for. Yes, it's all I've been on RadAid, and I must commend RadAid for the great work they've been doing for Kolebu all this, especially the radiology department. Yes, so we're using Clear Canvas from 2012 to 2015, where Mesh came into the picture, and then up to now.
So I'd like to follow up on that. And this is a question for both you, Ben, and Jason. So Jason, you are on the ground. You've seen what it's like. So I'm curious, if you want to help the listeners paint a mental picture what it looks like. KBTH and other similar institutions in continents like Africa, what does it look like? What are your challenges? And what kind of advice would you give to peers of yours, say, around Africa who are looking to improve their imaging workflows?
Yeah, absolutely. It was quite an experience when I went on site there. There were two modalities, a CT and an MRI, that were digital and contributing to the packs. However, they were not in commission when we showed up. So we had to walk through a few challenges like that. The interesting thing I find is you see this in art, and often when there's constraints and resources are limited, you see things flourish. And you see this here where there was a lot of maybe things that we wouldn't have done here because we have more resources at our availability. But there's a really interesting things that were being done at Kolebu when I showed up on how they were leveraging the clear canvas viewer and things like that for testing and so on. So yeah, it's really interesting. I would encourage anyone here to volunteer, any listener that's listening to this, volunteer. The SIMRAT Global Ambassador Program, I'm sure will be restarting as COVID dies down. So yeah, definitely volunteer. And Ben, over to you for your thoughts.
Most importantly, as rightly said, our CT was down, and so we're doing virtual image transfer from our modalities. What were those simulators? Yeah, so we have pack simulators that were pushing images from here to the devices to be able to communicate with them. One key important item to mention is storage. In medical imaging, you need ample storage. So from 2012 up to date, RadAid has been supporting with servers, the hardware, storage, servers, everything. As time goes on with deployment of the EMR, we realize there's a need to expand our data center. So here in Kolebu Radiology Department at the IT office, we have rack-mounted servers that seem to look like a daisy chain with external storage, ample storage connected, 8 terabytes, 40 terabytes connected back and forth. But it is important for medical imaging. We set up better data center with network, internal storage system that seeks to synchronize all our data, redundant servers that are able to respond when the main server goes down, proper power management, where there's power surge, like and forth. So I think the lesson we have learned what I think I share for developing countries is that when they want to set up an imaging center, they need to think storage, backup storage, ample backup storage, and then power plans for automatic power take up. When there's any power fluctuations, a system that is robust enough to sustain them when there's power fluctuations and the like. Yeah. So I think that's what I can say for now. Yes.
Well, thank you very much, Ben. We really enjoyed this conversation. It's really nice to check in and see how things are going there. It'd be nice to maybe we can keep this up and we can check in with you in a couple of years from now and see how things are continuing to evolve at KBTH. And hopefully we can see you at SIM sometime in the next little while, either virtually or physically. So
Yes.
thanks a lot again. Really appreciate this, and I'm all the best.
Simcast has been brought to you by the Society of Imaging Informatics in Medicine. Please visit our website at siim.org for more information and educational content, including webinars and an archive of prior episodes. Please follow us on Twitter at sim_tweets. Thank you to our listeners for your continued support.